Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving deep into a topic that is incredibly important for anyone in the veterinary field, and for many dog owners as well: mast cell tumors. You might have heard of them, or perhaps you've even managed cases yourself. They are the most common malignant skin tumor found in dogs, accounting for a significant portion of all skin cancers, with studies showing they make up anywhere from 11 to 21% of all skin neoplasms. In some regions, like Brazil, that number can be even higher, making it the second most frequent malignant tumor in dogs, right after mammary tumors. Given how frequently we encounter these tumors, a thorough understanding of their diagnosis, treatment, and prognosis is absolutely essential for providing the best possible care to our canine patients. In this episode, we'll be exploring the full spectrum of this complex disease. We'll start with the basics. What exactly are mast cells and how do they become cancerous? We'll look at which dogs are most at risk, examining factors like breed, age, and genetics. Then, we'll walk through the diagnostic process, from the initial clinical signs to the crucial role of cytology and histopathology. We will spend a significant amount of time on the two most critical aspects of managing these tumors: staging, which tells us where the cancer is, and grading, which tells us how aggressive it is. After that, we'll take a comprehensive look at the vast array of treatment options available today, from the mainstay of surgery to radiation, chemotherapy, and exciting new targeted therapies. Finally, we'll wrap up by discussing what the future holds, summarizing the key prognostic factors that help us predict outcomes and looking at promising new research on the horizon. So, let's get started. First, let's understand the cell at the heart of this disease. Mast cells are a type of immune cell, originating from pluripotent hematopoietic stem cells in the bone marrow. After they're formed, they travel to various tissues throughout the body, especially those that interface with the outside world, like the skin, the respiratory tract, and the gastrointestinal tract. In their normal, healthy state, mast cells are vital defenders. They play key roles in the innate immune response, wound healing, hypersensitivity or allergic reactions, and even fighting off parasites. They are packed with distinctive granules containing powerful chemicals like histamine and heparin, which they release in response to various triggers. A mast cell tumor, then, is a neoplastic, or cancerous, proliferation of these very mast cells. So, which dogs are most likely to develop these tumors? Well, they typically appear in older dogs, with the mean age of development falling between 8 and 9 years old. However, they have been seen in dogs as young as 7 months, and the odds of developing a mast cell tumor increase dramatically with age. One study reported that dogs over 10 years of age have a 41 times greater chance of developing a mast cell tumor compared to dogs under 2 years old. While some older studies suggested a gender tendency, more recent work has found no overall sex predisposition for developing a mast cell tumor. Interestingly, though, one study did find that male dogs are about 25% more likely to develop the histologically high-grade, more aggressive form of the tumor, and that neutering seemed to have a protective effect, decreasing this risk in males by about 40%. Breed is another major risk factor, and it's quite a significant one. Certain breeds are well known to be predisposed to developing mast cell tumors. This list includes the Boxer, Golden Retriever, Labrador Retriever, Shar-Pei, Bull Terrier, French Bulldog, and Dachshund. In fact, retrievers as a group seem to be particularly overrepresented, with one study finding that Labrador Retrievers, Golden Retrievers, and Retriever mixes accounted for up to 39% of their high-grade tumor cases. On the flip side, some breeds appear to have a lower risk, including the German Shepherd, Yorkshire Terrier, Poodle, and Cocker Spaniel. Beyond just the risk of developing a tumor, breed can also be associated with the tumor's likely biological behavior. For instance, Pugs and Boxers tend to develop tumors that are less aggressive, whereas Shar-Pei are known for developing more aggressive, high-grade tumors. The exact cause, or etiology, of mast cell tumors hasn't been fully figured out yet. Some have suggested that factors like chronic inflammation in the skin or exposure to irritating compounds could play a role. However, the most significant area of research has focused on genetics, particularly on a gene called CKIT. This gene provides the instructions for making a protein called the KIT receptor tyrosine kinase, which is found on the surface of mast cells. Normally, this receptor is activated when a specific molecule, called stem cell factor, binds to it, signaling the mast cell to grow and divide. In about 10 to 45% of canine mast cell tumors, mutations are found in the CKIT gene. These mutations, most often a type called an internal tandem duplication, cause the KIT receptor to become permanently switched on, even without the stem cell factor present. This leads to uncontrolled cell survival and proliferation, which is a classic hallmark of cancer. The presence of these mutations, especially in a region of the gene known as exon 11, is often associated with more aggressive tumors and a worse prognosis. Now that we have a foundational understanding of what these tumors are and who they affect, let's move on to what they look like and how we diagnose them. One of the most challenging aspects of mast cell tumors is their incredibly variable clinical appearance. They are notorious for being the great pretenders, because they can look like almost anything. The majority present as a solitary lesion, though about 11 to 14% of dogs will have multiple tumors at the time of diagnosis. A tumor might be a small, well-defined, hairless bump that has been there for months, or it could be a rapidly growing, ulcerated, and poorly demarcated mass that is clearly invading the surrounding tissue. Some are firm, some are soft, some are itchy, and some are not. They can even appear as soft, fatty-feeling lumps under the skin that look exactly like a benign lipoma. A classic, though not always present, sign is a history of the mass fluctuating in size, which is due to the periodic degranulation of the mast cells within it. The location of the tumor is also important. About half of them occur on the trunk and perineal regions, with another 40% on the limbs, and about 10% on the head and neck. Certain locations are associated with a more aggressive biological behavior and a worse prognosis. These high-risk locations include the muzzle, mucocutaneous junctions like the lips, the scrotum, the prepuce, the nail bed, and the perineal region. For example, tumors on the muzzle have a particularly high rate of metastasis to the regional lymph nodes, with some studies reporting that this has already occurred in 50 to 60% of cases at the time of diagnosis. In addition to the physical appearance of the tumor itself, dogs can also show clinical signs related to what are known as paraneoplastic syndromes. These are systemic effects caused by the tumor, specifically from the degranulation of the neoplastic mast cells and the massive release of those biologically active chemicals we mentioned earlier, like histamine and heparin. One classic sign you might see during a physical exam is called Darier's sign, where simple palpation of the tumor causes localized erythema, or redness, and edema, or swelling. The release of histamine can also cause significant problems in the gastrointestinal tract. High blood levels of histamine stimulate the H2 receptors on stomach cells, leading to excessive gastric acid production. This can cause gastrointestinal ulceration, which is found in a large percentage of dogs with mast cell tumors at necropsy. Clinically, this can manifest as vomiting, sometimes with blood, loss of appetite, black, tarry stools known as melena, and abdominal pain. Other paraneoplastic effects can include delayed wound healing after surgery, coagulation abnormalities due to heparin release, and though less common, severe systemic reactions like hypotension and circulatory collapse. Given their variable appearance, the first step in diagnosing any suspicious skin mass in a dog is often a fine needle aspiration for cytology. This technique is the cornerstone of the initial diagnostic investigation. It is quick, minimally invasive, relatively inexpensive, and can often be performed during the first consultation without sedation. Most importantly, it is highly accurate, providing a correct diagnosis in 92 to 96% of mast cell tumor cases. The procedure involves using a fine needle to collect a sample of cells from the mass, which are then placed on a microscope slide and stained. Under the microscope, mast cells have a characteristic appearance, typically being round cells filled with those distinctive purple or basophilic granules. It is important to use the right kind of stain. Stains based on the Romanowski technique, such as May, Grunwald, Giemsa, are very effective at staining the granules. Some rapid stains, like Diff Quick, can sometimes fail to stain the granules, especially in less differentiated tumors, which can make diagnosis more difficult. In those more aggressive, high-grade tumors, the cells may not have as much obvious granulation, but even then, a diagnosis can often be made based on other cellular features. Once a diagnosis of mast cell tumor is made, the next steps are arguably the most critical for the patient's outcome: staging and grading. These two processes are fundamental to determining the prognosis and creating an effective treatment plan. Let's start with staging. Staging is the process of determining the extent of the cancer within the dog's body. In other words, has it spread, and if so, where? The recommended staging workup always begins with a minimum database, which includes a complete blood count, a serum chemistry panel, and most importantly, a fine needle aspiration of the regional lymph nodes that are expected to drain the tumor site. For tumors that have features suggesting a higher risk of malignancy, like being large, rapidly growing, ulcerated, or located in one of those high-risk anatomical sites, a more comprehensive staging is recommended. This would typically include an abdominal ultrasound to evaluate the liver and spleen, often with fine needle aspiration of these organs as well. Thoracic radiographs, or chest X-rays, are also often performed, though they are less likely to show metastasis from a mast cell tumor. Their main utility is to screen for other unrelated diseases or to evaluate lymph nodes within the chest, which can be the regional nodes for tumors on the ventral abdomen or flank. The evaluation of the lymph nodes is a crucial part of staging because the regional lymph node is considered the first and most common site of metastasis. However, identifying the correct lymph node to sample can be a challenge. The lymphatic drainage patterns from a tumor can be aberrant and unpredictable, meaning the closest lymph node anatomically may not actually be the one draining the tumor, which is called the sentinel lymph node. Studies have shown that the clinically predicted draining lymph node is only correct about 55% of the time. Techniques like lymphoscintigraphy or contrast-enhanced ultrasound can be used to more accurately map the lymphatic drainage and identify the true sentinel lymph node. It is vital to aspirate the regional lymph nodes for cytology regardless of their size or feel on palpation. Histologically detectable metastasis has been documented in nearly 50% of lymph nodes that were considered to be of a normal size. While cytology is a good screening tool, it can produce false negatives, so in some cases, complete surgical removal and histopathological analysis of the entire lymph node, a procedure called a lymphadenectomy, is recommended for the most accurate staging. When it comes to looking for distant metastasis, the liver and spleen are the next most common sites after the lymph nodes. The appearance of these organs on an abdominal ultrasound is unfortunately a poor predictor of whether metastasis is present. Both the liver and spleen can look completely normal on ultrasound and still contain metastatic mast cells. Therefore, fine needle aspiration of these organs is recommended for complete staging, especially in high-risk cases. However, it is worth noting that for low-grade tumors, the incidence of visceral metastasis at the time of diagnosis is extremely low, with studies reporting rates of only about 0.7 to 4%. This has led to some debate about whether this invasive procedure is necessary for every single low-grade mast cell tumor patient. Based on all of this staging information, a clinical stage is assigned to the patient, most commonly using the system developed by the World Health Organization, which classifies tumors from stage 0 to stage 4. Stage 1 involves a single tumor confined to the dermis with no lymph node involvement, while stage 2 involves a single tumor with regional lymph node involvement. Stage 3 describes multiple tumors or a large, infiltrative tumor, and stage 4 indicates any tumor with distant metastasis to organs like the spleen or liver. There have been proposed modifications to this system to better reflect prognosis, as some studies have shown that dogs with multiple tumors but no lymph node involvement actually have a better prognosis than dogs with a single tumor that has already spread to a lymph node. Now, let's turn to grading. While staging tells us where the tumor is, grading tells us how aggressive it is likely to be. This is determined by a pathologist who examines a tissue sample, or biopsy, of the tumor under a microscope. Histopathological grading is considered the single most important and reliable prognostic factor for canine cutaneous mast cell tumors. For decades, the most widely used system has been the Putnamk 3-tier grading system, developed in 1984. This system classifies tumors as grade 1, which are well-differentiated tumors that generally have a benign clinical behavior and an excellent prognosis. Grade 3, which are undifferentiated, highly aggressive tumors with a high rate of metastasis and a poor prognosis. Or grade 2, which fall somewhere in the middle. The biggest limitation of the Putnamk system has always been the variability and unpredictability of grade 2 tumors. The majority of these will behave in a benign manner, but a subset, anywhere from 20 to 50%, will behave aggressively, and the grading criteria alone can't always distinguish between them. To address this issue, a newer, 2-tier grading system was proposed by Dr. Matty Kupel and colleagues in 2011. This system classifies all cutaneous mast cell tumors as either low-grade or high-grade based on more objective and strictly defined cellular criteria. A tumor is classified as high-grade if it meets specific criteria, such as having a high number of mitotic figures, which are cells in the process of dividing, or the presence of multinucleated cells or bizarre-looking nuclei. This system has been shown to have much better agreement between different pathologists and has been validated as a strong, independent predictor of tumor behavior, recurrence, and survival time. Currently, the consensus recommendation from many veterinary oncology and pathology groups is to use both the Putnamk and the Kupel grading systems together. This provides the most complete picture, especially for those challenging grade 2 tumors, which can be further subclassified as grade 2/low grade or grade 2/high grade, offering a much more refined prognosis. Another crucial prognostic indicator that is part of the histopathology report is the mitotic count. This is a measure of cell proliferation, determined by counting the number of mitotic figures in a standardized area of the tumor. A higher mitotic count is strongly associated with more aggressive behavior and a worse prognosis. One landmark study found that dogs with tumors having a mitotic count of 5 or less had a median survival time of over 70 months, whereas dogs with a mitotic count greater than 5 had a median survival time of only 2 to 5 months. With a definitive diagnosis, grade, and stage in hand, we can now turn to crafting a treatment plan. The approach to treating a mast cell tumor is highly individualized and depends on all the factors we've just discussed. However, for almost all cases, surgery is the mainstay of therapy, and for many dogs, it is the only treatment needed to achieve a cure. The primary goal of surgery is the complete excision of the tumor with adequate clean margins of healthy tissue all around it. For many years, the standard recommendation was to take wide margins of 3 cm laterally and 1 deep facial plane. However, research has shown that this one-size-fits-all approach may not be necessary for all tumors. For Putnike grade 1 and 2, or cupal low-grade tumors, several studies have now demonstrated that more conservative surgical margins of 2 cm laterally and 1 facial plane deep are sufficient to achieve a complete excision and result in very low rates of local recurrence, between 0 and 4%. For high-grade tumors, the situation is more challenging. These tumors are more infiltrative, and even with wide surgical margins, they have a high rate of local recurrence, with one study reporting a 36% recurrence rate even in tumors that were considered completely excised. If the regional lymph nodes are found to be metastatic, then a lymphadenectomy, or surgical removal of those nodes, is recommended not just for staging but also as a therapeutic measure. Removing the first site of metastasis can significantly reduce the risk of the tumor spreading further to distant organs and has been shown to improve survival times. But what happens if complete surgical excision isn't possible due to the tumor's size or location, or if the pathology report comes back saying the margins were dirty or incomplete? This is where other forms of local therapy come into play. Radiation therapy is a very effective option for improving local control. It is commonly used as an adjuvant treatment after an incomplete surgery. Studies have shown that for incompletely excised grade 2 tumors, radiation therapy results in excellent long-term local control, with remission rates of 94% at 1 year and 88% at 5 years. It can also be used for tumors that are not considered surgical candidates at all, often in combination with medications like prednisone, and can achieve high response rates. A more recent local treatment option is electrochemotherapy. This technique involves administering a chemotherapy drug, like bleomycin or cisplatin, either intravenously or directly into the tumor, and then applying a series of controlled electrical pulses to the area. These pulses temporarily increase the permeability of the cancer cell membranes, allowing much more of the chemotherapy drug to enter the cells and enhancing its cytotoxic effect. Electrochemotherapy can be used as the sole treatment for smaller nodules, applied to the surgical bed after a tumor is removed to treat microscopic residual disease, or used to treat a surgical scar where the margins were incomplete. It has shown very promising results, with high rates of complete response and good local tumor control, and it is generally well tolerated with few side effects. Another novel local therapy that has recently become available is an intratumoral injection called tigelinol tiglate, which is marketed as Stelfonta. This is a drug extracted from the seed of the Australian blushwood tree. It is injected directly into the mast cell tumor, where it works by activating a signaling cascade that rapidly disrupts the tumor's blood vessels and incites a very strong, localized inflammatory response. This leads to the death and necrosis of the tumor tissue, which then sloughs away over the course of about a week, leaving a wound that heals by second intention. In clinical trials, it has shown a high complete response rate, with about 75% of tumors being completely destroyed after a single injection. It is specifically indicated for non-resectable, non-metastatic cutaneous or subcutaneous tumors in certain locations, like the limbs, and it offers a valuable alternative for tumors that are difficult to remove surgically. While local therapies are focused on controlling the primary tumor, systemic therapies are needed for tumors that have a high risk of spreading, or have already metastasized. The most common form of systemic therapy is chemotherapy. Chemotherapy is generally recommended for all high-grade tumors, tumors that have already spread to the lymph nodes or other organs, or intermediate-grade tumors that have other negative prognostic factors like a high mitotic count. The goal of adjuvant chemotherapy, which is given after surgery, is to kill any microscopic cancer cells that may have already spread, thereby delaying or preventing the development of metastatic disease. Chemotherapy can also be used in a neoadjuvant setting, meaning before surgery, to shrink large tumors and make them more amenable to complete surgical excision. The most common and first-line chemotherapy protocol for canine mast cell tumors is a combination of the drug vinblastine and a corticosteroid like prednisone. This combination has been shown to be beneficial for dogs with high-grade tumors, improving disease-free interval and overall survival time compared to surgery alone. Another commonly used chemotherapy agent is lomustine, also known as CCNU. It is often used as a second-line therapy or in protocols that alternate between vinblastine and lomustine. These protocols have been shown to be well tolerated and can provide good disease control. In recent years, a new class of systemic drugs has revolutionized the treatment of mast cell tumors, tyrosine kinase inhibitors, or TKIs. These are targeted therapy drugs that work by interfering with specific molecular pathways that drive cancer growth. As we discussed earlier, many mast cell tumors have a mutation in the CKIT gene, which leads to a constantly activated KIT receptor. The two main TKIs used in veterinary medicine, tosarenib phosphate, Palladia, and mazatinib, Masavet, are small molecules that are designed to block the ADP binding site on this abnormal KIT receptor. This prevents the receptor from signaling and effectively shuts down the pathway that is telling the cancer cells to proliferate. Tosarenib also has the added benefit of inhibiting other receptors involved in tumor growth, including the vascular endothelial growth factor receptor, or VEGFR, giving it anti-angiogenic properties that can help cut off the tumor's blood supply. These drugs are licensed for the treatment of unresectable or recurrent grade 2 and 3 mast cell tumors. Initially, it was thought that they would only be effective in tumors that had the CKIT mutation. However, subsequent studies have shown that dogs with tumors that do not have the mutation can also respond to and benefit from TKI therapy. This suggests that these drugs have other anti-tumor effects beyond just inhibiting the mutated KIT receptor. In fact, the most significant predictor of long-term success with these drugs seems to be the patient's initial response to treatment, regardless of their mutation status. Some research suggests that traditional chemotherapy may be the better choice in the adjuvant setting for microscopic disease, while TKIs may be superior for treating macroscopic, measurable disease in a palliative setting. Finally, no discussion of mast cell tumor treatment would be complete without mentioning supportive and palliative care. Because of the systemic effects of mast cell degranulation, managing these paraneoplastic syndromes is a critical part of the overall treatment plan. This almost always involves the use of antihistamines. H2 receptor blockers like famotidine or proton pump inhibitors like omeprazole are used to reduce gastric acid production and prevent or treat gastrointestinal ulceration. H1 receptor blockers like diphenhydramine are used to counteract the other systemic effects of histamine, such as vasodilation and inflammation. It is standard practice to premedicate any dog with a mast cell tumor with an H1 blocker 30 to 60 minutes before any procedure that involves manipulating the tumor, such as surgery, biopsy, or electrochemotherapy, to prevent a massive, potentially life-threatening histamine release. So, pulling it all together, what does the future look like for a dog diagnosed with a mast cell tumor? The prognosis is incredibly variable and depends on a combination of all the factors we have discussed. The most powerful prognostic indicators remain the histologic grade, with high-grade tumors having a much poorer prognosis, and the clinical stage, especially the status of the regional lymph nodes. The presence of lymph node metastasis is a strong negative prognostic factor. Other important factors include the mitotic count, the presence of mutations in the CKIT gene, specifically in exon 11, and the expression of proliferation markers like Ki67. For high-grade tumors, the overall median survival time reported in one large study was 317 days, with a 1-year survival rate of 50% and a 2-year survival rate of 30%. However, this study also showed that dogs treated with surgery had a significantly prolonged survival compared to those who were not. Subcutaneous mast cell tumors generally carry a more favorable prognosis than their cutaneous counterparts, though a small subset can still behave aggressively. The field of veterinary oncology is constantly evolving, and new research is underway to find even better ways to treat this disease. Some promising future perspectives include novel therapies like electrogene therapy, which uses electrical pulses to deliver therapeutic genes like interleukin-12 directly into the tumor, and new classes of drugs like histone deacetylase inhibitors, which have shown the ability to reduce growth and induce cell death in mast cell tumor cells in vitro. In conclusion, canine mast cell tumors are a common and complex challenge in veterinary medicine. Their behavior can range from completely benign to highly aggressive and metastatic. However, we have a growing arsenal of tools to fight them. A successful outcome hinges on a meticulous and thorough approach that starts with an accurate diagnosis, followed by comprehensive staging to understand the extent of the disease, and precise histopathological grading to predict its biological behavior. This information allows us to create a tailored, multimodal treatment plan that may include surgery, radiation, chemotherapy, and targeted therapies. While high-grade and metastatic disease still present significant challenges, our ever-improving understanding of the biology of these tumors continues to lead to better prognostication and more effective treatments, offering hope and improved quality of life for many of our canine companions. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,